Retirement is supposed to mark the beginning of our golden years, a chance to pursue new interests and spend time with family. But for a growing number of seniors, the reality is bleaker. Struggles with maintaining health, loss of family and work roles, and coping with the deaths of peers and loved ones has led to increasing levels of depression. With the number of seniors increasing every year, this rise in depression among older adults presents a growing challenge for our healthcare system.
I find with even senior friends, the loneliness sometimes gets to them. Because we're used to being very active in our lifetimes, and then all of a sudden, it's not there.
There are very, very high rates of depression in older adults, 20 to 25%. It's being untreated.
This rise in depression among older adults has led to decreasing levels of functioning, reduced quality of life, and worsening health conditions.
Depression and anxiety disorders, what we sometimes call the generalized anxiety disorder, are two of the most important problems that primary care physicians face.
From my standpoint, especially with my elderly patients, I talk about the fact of depression as being something that complicates medical problems.
In fact, healthcare costs for seniors with depression are about 50% higher than for those without depression. One challenge is that older adults are not likely to seek treatment for depression.
I think the real issue for older consumers is a stigma issue. A lot of people grew up, that are in this cohort, grew up thinking that if you were depressed, it was sort of your fault.
Most people who have depression are afraid to admit it because they think someone is going to think they're crazy.
Fear of stigma among older adults is not the only inhibitor of successful diagnosis and treatment. Providers often overlook signs of depression or are uncomfortable asking about mental health issues.
There was this big misconception that because these folks were, maybe isolated because they weren't feeling well sometimes, or they had these chronic illnesses, or they, just by virtue of being seniors, of course they were going to be depressed.
Sometimes there's a tendency in medicine to focus on just one part of the human, to focus on the physical part and not the mental part. But in fact, particularly in older adults, we see both so commonly occurring at the same time that in order to provide high quality care, we really do have to be considerate of ways of treating the mental and the physical concurrently.
Researchers around the country are finding ways to do it. The Substance Abuse and Mental Health Services Administration's Center for Mental Health Services has identified evidence-based practices, or EBPs, in use around the country that are succeeding. Evidence-based practices include psychotherapy interventions and the use of antidepressant medications. These can be used individually or in conjunction to improve symptoms. They can also be used within models of outreach services and collaborative and integrated mental and physical care.
One of the issues was how to identify patients early on and how to provide the best kind of treatment given time constraints in primary care.
One model of care for diagnosing and treating depression in older patients is IMPACT, which stands for Improving Mood, Promoting Access to Collaborative Care. The Institute for Family Health partnered with the developers of IMPACT to implement the model in New York City.
Yes, it's Dr. Gayle.
The mission of the Institute for Family Health is to deliver private practice level quality primary care to an indigent population.
IMPACT is a collaborative model of care that seeks to identify and treat depression in older adults in a primary care setting.
Good afternoon, how can I help you?
Yes, good afternoon. I'm here to see Dr. Gayle.
Okay, let me step around and have a seat with me here, please.
The impact model helps promote a holistic view of patient care by integrating depression screening into chronic disease management.
It is the first time that there was a really publicized, research-based model that supported something which is near and dear to me, which is the integration of primary care and mental health services.
Today you're here for your physical, and part of what we do here is we ask all patients coming in for a physical to fill out or to answer questions about depression.
Project Impact attracted me and our organization because it enabled us to provide services to our geriatric population that were not being addressed previously.
The two key features of the impact model are screening for and tracking depression in a primary care setting with a patient health questionnaire and on-site collaborative care with the patient's physician.
When a patient comes in, they are checked in at the front desk. They are then transferred to nursing for an intake or triage process. And during that triage process, we've actually incorporated the PHQ too.
Okay, I have a few personal questions to ask you. This is completely confidential and it's for the use of the doctors only. Okay?
Over the last 2 weeks, have you been bothered by any of the following problems? Little interest or pleasure in doing things?
And if they score one question positive, it triggers us doing the PHQ-9.
This is a form called a PHQ-9, and I need you to read this and fill this out.
PHQ-9 is a patient health questionnaire that has 9 questions that are scored from 0 to 3, and the patient themselves answer it. So you're not diagnosing the patient, they're diagnosing themselves as to whether or not they have true depression or not. And oftentimes they're scoring with moderate depression, they're scoring 10 and above. And those are the patients that usually you're seeing much more frequently than you would expect to. These are the patients that are having more problems with their comorbid conditions, their diabetes, their high blood pressure, and so on and so forth. And once you start treating those patients with scores of 10 and above in the PHQ-9, you start seeing the improvements in the rest of their well-being. Well, my nurse told me that she gave you a patient health questionnaire for depression, so I'm just going to spend a couple of seconds on score to see how far along the curve you are.
We offer them problem-solving therapy. We offer them meetings with our psychiatrist to follow up on any kind of psychopharmacology. And we also offer them just touching base once a month by phone, because some people who might not want these other interventions, we want to keep on our radar, and we want to make sure that we're monitoring them on a monthly basis.
I'm going to talk to you a little bit about what the course of management is going to be. I'm going to give you the medication today, and I'm going to ask that you follow up with me in about 2 weeks. Anytime during those 2 weeks, if you're having trouble with the medication, you can call me. I'm going to get our psychosocial services colleague to sit with you. She's going to be talking to you about the course of management she will have with you. And I expect to see you again in 2 weeks. And
because we have the tools of the PHQ-9, I'm able to give a score, share that with the patient, and then we can say, well, we tried this last time, but even though you say you're feeling better, it doesn't really seem like your score has improved. Maybe we really should have you talk to somebody.
The physician can collaborate with the depression care manager and psychiatrists who are located on site.
In the Project Impact model, the depression care managers can be either nurses or they could be social workers.
So out of all those things that you mentioned, what is one that you would like to work on?
I want to go back to where I used to be, where I used to look forward to getting up in the morning, getting dressed and going out there, being around people. I don't feel that way anymore. I feel like another day, I gotta get dressed. Where am I going? I don't want to go out. I don't want that. I want
that energy
that
again.
energy that I had.
We make sure first that they're not in any danger to themselves, and then we set up a protocol where we offer them problem-solving therapy.
Well, the goal that we can work on is to get you back to where you were 3 weeks ago. That would be great, right?
Yes.
And to get you from being depressed to feeling like your normal self again. And those baby steps are called self-management goals. So there are goals that you establish for yourself that you
It gives the patient the opportunity to come up with what some of their problems are and how they even want to, get through some of the barriers that they're facing. The patient has a big say in, okay, so how do we get from here to here to here to really, slowly start to decrease these depressive symptoms, and it comes from them.
It's very difficult for older adults to seek treatment, to seek counseling on their own. And the primary care office is a very good entry point for the patients to be identified as depressed if they are, which usually older adults would go undiagnosed. We help people to reduce their depression.
What I found with this particular model is it did identify patients before sometimes I was aware that they were suffering from depression.
He told me the results of his interview. I said, you saw all that? He said, yes. I said, well, I better think about it, because I wasn't aware that I had a problem. But he thought I did, and he probably was right. And I enjoyed talking about my daily life, which has been changed so very much. And it was a wonderful experience.
Most of these patients have functioned well for most of their life, and they just really need some extra support now in how to get, from the problem to feeling better.
I met with Miss Brown.
Yeah, thanks for seeing her. I'm going to see her in 2 weeks. How did your interaction go with her?
It went well.
Now, part of the challenge for me is finding the time to spend to manage this patient. And if I can reach across the hall and get my social service specialist on board to say, listen, I don't have time right this minute. Can you spend some time with this particular patient while I go do that? By the time you're finished with her, I can come back and perhaps discuss other management with the patient, including medications and so forth. It makes the flow so much easier. You're not having the patient run around to different areas trying to find the services that you can provide right on the premises.
I would say the number one thing is getting the doctors on board and the doctors to buy into the program and recognize how it's going to both help their patients and help the practice.
Having the social worker integrated into the whole process provided a strong support for the primary care providers, and also made it easier for them to intervene because they didn't feel like they were carrying this whole burden on their own.
The use of the screening tools for Project Impact has enabled us to demonstrate the improvement in the PHQ-9 scores for the patients in the project.
We like to measure things, and you can measure the PHQ-9 score. You can measure the diabetes evaluation on their hemoglobin A1C, whether or not they're getting better. You can see that the blood pressure is getting better. All of these things makes it more satisfying in treating our patients.
This program is very easy to implement once it's rolling. It's very simple to screen patients and provide them with needed medication or counseling and support to improve their lifestyle.
All of that integration of the medical information and the psychiatric can be very nicely utilized to form as accurate a picture of the patient's diagnosis as possible.
So it really was Depression 101 to discuss what are the signs of depression, what is helpful for a patient to reduce their depression in order to help their medical condition. So the patient is not coming through the door every 2 weeks for another problem.
If we can make it easier for them to access services that they need, I think that's very exciting.
Integrated mental and physical health care services have been proven to work well in reaching many older adults. But what about older adults who may be falling through the cracks of primary health care? Psychogeriatric Assessment and Treatment in City Housing, or PATCH, is a mobile treatment program developed at the Johns Hopkins Hospital in Baltimore. It targets older individuals with mental illness whose needs are not being met by the traditional healthcare system. It combines the mobile treatment model and the Spokane gatekeeper model and adds elements that address the medical and social challenges that are so prevalent in this group.
People who lived in public housing sites had 3 times the rates of depression and several other psychiatric disorders as elderly people living in the community. So we knew we had a very high risk, high prevalence population in public housing.
We're serving the most vulnerable elderly population. It's the impoverished elderly with mental illness who are socially isolated for the most part, and who won't access traditional care.
Hello. Good to see you again. Yeah, okay. That's what you do all. Persons that we work with, for the most part, are not going to seek traditional mental health services.
With social, physical, and psychiatric issues compounding each other, the needs of these older adults often go unaddressed.
And you come to realize that the best way to improve the quality of life for seriously ill older individuals is to simultaneously try to address their social, medical, and mental health needs.
Now, are you tired during the day?
I get tired.
Do you fall asleep, take cat naps?
Yeah, I do.
Yeah. Sometimes I know it's hard, but if you can keep yourself from doing that, you'll probably sleep better at night.
That's right.
We developed the program about 20 years ago after actually failing to reach this population through more traditional programs. And then the idea of providing both mobile treatment, but also using what was called the gatekeeper model, in which people in the community were used to identify people who might need mental health services. We combined those two together and launched the program back in 1986.
The gatekeepers for the Patch program are housing authority staff who have been trained to recognize potential signs of mental illness in older residents.
The nurses will initially provide educational programs for staff that work in the housing authority buildings, and this would include managers, counselors, security staff, anybody that may come in contact with a resident that is ill and in need of services.
How you doing, Miss Rachel? What's the name? How's that tub shower? The shower tub we gave you, is that all right? Okay. You like it?
The maintenance staff is also involved. They're maybe the first contact in some cases.
I'm glad you can use it. Yeah. All right, take care. Thank you very much. All right.
The Patch program has been very, very helpful with identifying as well as following up on things that we identify to help people not be evicted, not be in their units without taking their meds, not being there without anyone to speak with as far as making doctor's appointments or even eating on a day-to-day basis.
Once we recognize or think that we recognize a particular situation, then I call Patch, ask them to come out, and they will do an intake to verify and then hopefully beginning to support that particular individual.
The Patch teams include a nurse, a geriatric psychiatrist, and a case manager who bring services directly to residents in their homes. Once housing authority staff identify a resident who may be in need of services, a visit from a Patch program nurse is usually the next step.
The reason we've chosen at the beginning to use nurses is because many of these patients turn out to have unmet medical need as well as unmet psychiatric need.
We do a mini mental in everyone initially, as well as a depression scale and a psychotic type of scale. Do you know the name of the program I'm with? It's called Patch. Yeah, Patch. Mm-hmm. You know, the brochure I gave you, actually...
We're asking demographic information, medical history, psychiatric history, medication list if it's possible, and then a general listing of, it's sort of a yes-no listing of all possible medical diagnoses that the folks may have.
Did you bring this whole card in when you went to see him?
Yeah, I took this to the doctor.
The big pink one is called Depakote.
Depakote?
Mm-hmm.
I didn't know the name.
The second element then is to have a trained geriatric clinician make contact with the person, offer our services, do an assessment.
Very good. And
So, so we gotta get, so you've been in a nursing home lately? A lot of times?
Never been there.
That's what Miss Mary was saying, that you've had to go to the nursing home a few times.
Oh yes, it's just something I do. It's a habit.
Habit, yeah. I got a lot of bad habits myself. The minute you walk in someone's house, you know more than you'll ever learn, you know, following somebody for years in a clinic. And then this one, how's your reading? Do you read okay?
The psychiatrist does standard psychiatric diagnostic visit, and then together with the client, develop a treatment plan. And that's when we decide whether we really want to include the services of the case manager.
It's done very well, actually.
Right. All right, Mr. Williams, it was good meeting you. All right.
See you later.
Bye. See you later.
In addition to addressing the medical and psychiatric needs of their patients, the Patch team can include a case manager to address social and financial challenges that may exacerbate their other needs.
So her certification review with mobility is scheduled for the 24th of March, so that's already been set up as well.
Buck Weeks is a Patch case manager who works with the treatment team to address these challenges.
You get Social Security each month for your money? Now just time.
So he'll come in and help with entitlements, transportation, making arrangements for meals. I mean, the list is endless for what he does.
Do you remember discussing that?
Yes, sir.
What I help do is work as part of the team with the nurses and the psychiatrists, coordinating services for the people we serve, helping take care of medical appointments, monitoring medical appointments, helping solve any problems with benefits, entitlements, and resolve any conflicts that occur.
Okay.
And then this is just so you know how they came up with that number.
Okay now.
Sometimes there's not a whole lot of communication between different doctors, different services, and the family. And when people are getting older, they're having trouble remembering who they spoke to, who told them what. They don't always accurately relay the information to other doctors, other family members. So by being in touch with every treatment team member and being able to be like the hub, it gives me a chance to make sure that all the services are complete.
Not all residents are immediately receptive to services, even services that are brought directly to their homes. The nurses and case managers have found that developing a relationship with the client and being able to help them with even one of their problems can help make that client more interested in other services.
They will let a nurse in the door. Many people are used to home health nurses coming out or public health nurses coming out. And if you somehow find a way to help them with something that they think is necessary, which usually is not their medical illness or their psychiatric illness, then you have a way in to get the rest of their needs addressed. So sometimes it takes a while to establish a rapport.
Good. Do you know where your wife is buried?
Sure.
If they could help you find out where your wife is buried?
Yeah.
Then you may be having your niece or your nephew go find where she is. All right.
I would like to know.
I think that's a good idea.
But then again,
Time spent listening, hearing what someone's saying, and knowing them over time so that you actually can anticipate or even name what others just are not seeing. I think that's a key piece to persons beginning to stabilize, because oftentimes they don't feel that they've been heard.
If we can initially get medical problems or their social problems treated, then they're more receptive to getting the psychiatric problems treated.
The goal of Patch is to stabilize older adults through in-home treatment and then transition them to traditional mental health services after 6 months.
Once Patch becomes involved with a resident, we see them coming out more. We see them interacting more in the lobby area with our staff.
When they come there, I'm cheerful, I'm happy. I know they're gonna be there. Especially I know she'll be there every Tuesday.
And we found that we could decrease rates of depression and depressive symptoms by about 20% in the buildings we intervened in, whereas the buildings that we did not intervene in, actually depression rates went up over 2 years.
Without the Patch program, I could see individuals being placed in nursing homes. I can see individuals becoming homeless because of dementia. I can see individuals simply shutting down.
As a nation, as a healthcare system, here's a group of people we can make a huge difference with by relatively simple but focused programs. And I'm proud of the state and the city that for almost 20 years they've been willing to support this from the state level.
People can be treated. People can have full and good lives, but not if they're not treated, if they're not identified.
We hear this all the time, that we've made a difference in people's lives, and we've improved their quality of life, and that helps us keep going.
Depression does not have to be a part of aging. The impact and patch models are just two examples of the many practices that are being put to use to successfully identify and treat depression. If you would like more information about evidence-based practices for treatment of depression in older adults, go to samhsa.gov/shin or call 1-877-SAMHSA-7.
I think people should realize that because you're older, it doesn't mean you have to be depressed.